I'm Mauricio Towen, and I'll be introducing our speaker today. Our speaker today is Dr. Dost Öngür, who is a native of Istanbul, Turkey. He obtained his MD Ph.D. at Washington University in St. Louis with a Ph.D. in neurobiology. He then completed his residency training at MGH McLean Adult Psychiatry program in 2004 and subsequently stayed as faculty at McLean Harvard Medical School. His research has focused on brain imaging approaches to probe brain abnormalities in psychotic disorders, as well as in clinical studies to understand the trajectories of illness in early phases of these disorders. That's something that we have in common with Dr. Öngür, our interest in the trajectory of psychosis from the early beginnings. Now, Dr. Öngür has a P50 Center grant from NIMH with a focus on early psychosis research. And we know that when you get a P50 as a PI, that is truly that you are an expert in the field. That follows the K Award and the R01, so congratulations for that, Dr. Öngür. Dr. Öngür is currently the chief of the Psychotic Disorders Division at McLean Hospital. He's responsible for all clinical services serving patients with psychotic disorders, including first episode psychosis. I must mention that I guess I had the honor of having that position, I'm afraid to say 2 decades ago, but that's when it was. Dr. Öngür is a William P. and Henry B. Test Professor of Psychiatry at Harvard Medical School. He's the author of more than 200 articles on research into the neurobiology of bipolar and schizophrenia. He has won numerous awards, including those at McLean Hospital, at Harvard Med, and the Kemp Award from the APA for his teaching and mentoring. He is the editor-in-chief of JAMA Psychiatry, who some would call one of the premier journals in the field. I would call the premier journal in the field. It is an honor to have you here, Dr. Öngür. Dr. Öngür.
Thanks so much, Dr. Towen, for the invitation and the introduction. Yeah, it's been great to follow in your footsteps here in Massachusetts at McLean. Working on the same services that in some of them you started and studies, some of them you started while you were here. So it's great to be with you this afternoon. Well, for me, it's afternoon. It's just for you too as well, right? So, so as you heard, my research has been focused mostly on psychotic disorders and the earliest phases of psychotic disorders. And today I'm going to present to you what I see as the state of the field in early psychosis. Some of this will be our own work, especially towards the end from that P50 grant that you heard about. But I'll start with really a broader perspective, hopefully to give you a sense of the excitement and the promise of why we think that this is an important direction to go. So this is my funding and disclosure slide. I did have one relationship with a for-profit entity. I received honorarium from this company. It's always good to be aware of that. So the outline, I'm going to talk about the philosophy of early intervention, why in the field there's so much interest in this and how to think about it. And then the earliest stages of illness, the emergence of psychosis. Then I'll focus on the early psychosis treatment issues, some of the debates in the field. And then I'll talk about Epineph, which is the Early Psychosis Intervention Network, which is a nationwide consortium. Hopefully give you some details about what that is and how it's going. And then our own LEAP Center, which is a laboratory for early psychosis at McLean. That's this P50 grant funded center. And then Mapnet, which is the Massachusetts branch of Epineph, and leave you with some conclusions. So why are we interested in early intervention? I really like to start with this slide, because it's really about something so important and the visual representation is so striking. Here you're looking at the proportion of people who are alive at any given age, and you see the ages on the x-axis here. And for men on the left, women on the right, the orange is the general population. And you see that most people are alive until you hit your 60s, 70s, and then into the 80s, there is this inflection point. And then by the time you get out to the 90s and beyond, there's few people left alive. And in yellow is the same thing, but for people with schizophrenia, and green is the same thing, but people with bipolar disorder. And you see how starting at the earliest ages, there's such a decrement in the proportion who are alive. So these are fatal disorders for an important proportion of our patient population. And then on average, our patient population lives 15 to 20 years shorter than they would be expected to. So this is a big public health challenge. It's not just a academic interest or theoretical interest. This is about life and death, and we need to understand better how to change these outcomes. So psychotic disorders are a significant public health burden. There is non-adherence, frequent relapse, ongoing disability. You know the clinical picture. Those of you who work with these patients know what it's like over time, how much morbidity there is. But interestingly, long-term outcomes following a psychotic disorder diagnosis are not always adverse. Many people regain functionality. A few will require little or no care. So good outcomes are possible. It's just that that's not common. And then on the other hand, we have the clinician's illusion, which leads to pessimism and wrong messaging for patients and families. If you're sitting in a clinic and just seeing patients who come to see you, you're only going to see the people who are sick, because the people who are doing well just don't come in as much. And so if that's what you do, you're gonna think that all of our patients are actually doing poorly, but that's actually a clinical's illusion. So when we tell patients and families outcomes are poor, you're gonna have a lot of problems, this is never gonna go well, that doesn't actually do a service to our patient population. And in fact, there's lots of data out there about this. I have one from Australia up here and one from the UK down here, and you'll see that basically half of all people can have symptomatic remission, and the third of them can have social vocational recovery over the first couple of years. And then, when you break it down to affective and non-affective, of course, those with mania are actually in even better shape. The majority of them are going to be considered recovered after a couple of years. There's actually, I should have included the McLean data, which Dr. Tohen started, starting in the 90s and then into the 2000s here. Those numbers are similar, if not better. So, recovery is very real in these conditions. Mental disorders are chronic diseases of the young, with their onset and maximum impact in late adolescence and early adult life. This is a quote from a paper by Pat McGorry, who's a leader in this field out of Australia. So it's a big deal, and recovery is possible, but you're dealing with these conditions that are going to be relapsing, remitting for most of people's adult lives. And it's actually unusual in all of medicine to find such a disorder that is such a big deal and yet sticks with you for most of your adult life. Early manifestations are fluid, long-term outcomes are variable. So we have to find ways to intervene early so we can improve outcomes in the long term. And I'll give you one of the punchlines right off the bat. The neurobiology and epidemiology research indicate that psychotic disorders have significant developmental components. So what happens to you when you're 18 or 20 or 25 and you get diagnosed with schizophrenia or with bipolar disorder is not the beginning of the illness. That's actually the culmination of a process that starts with your genetics and intrauterine development, what happens to you at birth, especially perinatal hypoxia, difficult births with hypoxia, the damage that is caused to the brain can increase the risk of psychotic disorders, and then exposures in early childhood to adverse childhood experiences, and then in adolescence, especially cannabis use. Those are all, hits to the developing brain that manifest themselves ultimately as schizophrenia or bipolar disorder in late adolescence and early adulthood. So this developmental component is really important. And if you think of it that way, then you see that the onset of a psychotic disorder is a critical window of opportunity for intervening to prevent long-term disability, not as the start of inexorable decline. So this is not destiny, and we need to try to get our patients better outcomes from day one. And the focus should be on improving long-term outcomes with systematic early delivery of existing and incrementally improving care. And this should be stepped intervention, so commensurate with the magnitude of the problem. One of the good examples of this is the use of antipsychotics, which are really not indicated in at-risk states in people with clinical high risk. And I'm going to come back to this clinical high risk CHR population in a minute. And also in first episode, the recommendation is to use the lowest possible dose. So antipsychotics are not considered, right off the bat, maximize the dose and keep people on that dose. And that gives you an example of the stepped care idea. I mentioned the developmental aspects. I'm not going to go into detail about this slide. It's a complicated slide about brain biology. The point that it makes is that a lot of brain development is taking place in utero here in the mother's womb and then in early years of life. And many of these processes, like the development of synapses between nerve cells for communication, are actually ongoing even after birth for years and into adolescent years. And then in people with schizophrenia specifically, there's deviation from normal. So you see in the blue curve here, people with schizophrenia showing deficient myelination, that's the white matter tracks that are connecting different brain regions, that's become abnormal. And also in synapse formation, in the connections between nerve cells, it's already abnormal at age 5, 10, 15, 20, leading up to the diagnosis of schizophrenia. And so if we could intervene early, we might be able to reverse some of that. So a neurodevelopmental perspective argues for both primary prevention, so reduce exposure to offending factors, and maybe you will prevent some of the bad outcomes from schizophrenia. So, reduce poor prenatal care, reduce adverse childhood experiences. There's a growing literature actually on urban child rearing, especially air pollution, but even things like light and noise pollution might disrupt the developing brain, and that's something to be mindful about. And then especially cannabis in adolescent years as a risk factor. So if we could reduce all of these factors, you might actually reduce the morbidity that comes from psychotic disorders, and that's primary prevention. But then there's also secondary prevention. Once somebody has psychosis, can you do early detection and early intervention? Because the earlier you intervene, the better the chances of preventing those developmental processes from becoming abnormal. And that, of course, should change the long-term outcome for our patient population. This graphic is an old one. It's a textbook figure showing how people who develop schizophrenia in the premorbid period have certain, sort of developmental stage, but then as they start to become sick, their clinical manifestations and functioning become abnormal, become disrupted, and eventually, after about 10 years of illness, many patients settle into this chronically ill residual mode. And the question really is this red line here. Can we do early intervention to bend this curve, to prevent this decline? Because if we could, that could really change outcomes for a lot of our patients. One of my mentors was Larry Seidman, who was a leading figure in this research here in Boston. He passed away unexpectedly a few years ago. And he used to say early intervention is not just about, the outcomes and what treatments we should provide. It's really a social reform movement because it can change how we, in society, we think about psychotic disorders. When in society, many people think of schizophrenia, they think of violence, they think of jails, they think of scary things. The reality is that we want to transform that. And when people in society think about schizophrenia, we want them to think about early intervention, better outcomes, good lives that people are happy leading. We're not there yet, but that should really be the long-term goal here. So focusing a little bit on the earliest stages, the emergence of psychosis, and specifically those at-risk states. Clinical high risk, or CHR, is a term that's becoming commonly used in the field because many people who develop schizophrenia and also other psychotic disorders go through a period where they're in this at-risk state, and it's possible to identify them and to intervene and to do something to help them. This is another really complex slide that I'm not going to go into all the details about, but I like to show it because it shows the diversity of pathways to getting to schizophrenia. Some people develop what are called APS, which is attenuated positive symptoms. So before they develop schizophrenia, they have attenuated symptoms. They might think that everybody's talking about them or there is a conspiracy against them, but they can actually reality test around that and tell themselves, well, I know I feel that way, but it seems like that wouldn't happen. Doesn't make any sense. Those are the attenuated symptoms before they develop psychosis. Some people actually have what are called blips, or brief limited intermittent psychotic symptoms. Those may be full-blown, but they're limited and they don't last very long. And then they go away, but then schizophrenia comes in for good later. Other people might have actually neither of those, but they might have cognitive dissonance, which refers to abnormalities in the experience of the self and people feeling like they are not where they belong, society isn't what it seems like it should be. There's a sense of unreality to the world, and then later they develop schizophrenia. So there's a lot of different pathways to getting to schizophrenia and psychotic disorders. And these are different from one another, but they actually share the characteristic of being there in this clinical high-risk state, or CHR. There is a growing number of clinics around the country treating these at-risk states. Their goals are things like improving the detection of at-risk individuals in the community. So there's actually a screening function to seeing these young people and serving their needs. Then there is serving the clinical need for help-seeking individuals if they are depressed or anxious or using substances. There's something you can do about that, and these CHR clinics will do that. Prevent the onset of psychotic disorder. Maybe if we're lucky, we could actually catch people in their CHR states and prevent the onset of psychosis. That's a tall order. We're not there, but that's one of the hopes or the goals of these clinics. Shortening, and if you can't prevent it, at least what's going to happen is that if they're in your clinic, you're going to know when they develop full-blown psychosis. So you will shorten the duration of untreated psychosis. If people are out there in the community with no help whatsoever and they're psychotic, it's going to take longer for them to come to some kind of attention. So we can reduce the DUP, the duration of untreated psychosis. And there is a large literature that suggests that the longer the DUP, the worse the ultimate outcomes. So if you shorten DUP, we might improve outcomes. And then in general, reducing symptom burden and disability. So these clinics are popping up in various places, and we're going to hear more about it in the coming period, because the NIH actually recently invested in a big consortium of CHR clinics to collect more data and to understand better this process of the development of psychosis. Speaking of these at-risk states, there's a couple of other things I want to highlight. One is cannabis, and the other is stimulants. I already mentioned cannabis, and there's really good evidence that cannabis is in teenage years is a risk factor for developing psychosis. The causal relationships, whether cannabis really causes psychosis, is really difficult to tease out. There's a lot of debate about that, but you don't have to believe in the causal relationship in order to be concerned that if you have a teenager who's smoking a lot of weed, they are already marking themselves as being a higher risk for psychosis. And I like this paper from Eden Evans, who's at Mass General down the road here from us, and her colleagues, where they make the point that the time is right for the United States to follow Canada's lead and invest in public health education and messaging regarding cannabis as legal but not safe for young users, particularly of high potency products. So this debate is not about whether cannabis should be legal or illegal, because that horse is out of the barn. Many states around the country have already legalized cannabis. I don't actually know what it's like in New Mexico, but here in Massachusetts, we have both medicinal and recreational. We have cannabis dispensaries, with billboards on the side of the road saying, come here and buy your weed from us. And so it's totally legal. Anybody can walk in after age 21 and purchase their weed. You don't need any special, cards or anything else. But the problem is that teenagers who are smoking a lot of weed are at high risk for psychosis. So we don't have to say, keep cannabis illegal. But what we have to say is that society needs to have the message that teenagers smoking weed are at high risk. Okay. And the other issue is stimulants. My colleague Lauren Moran here at McLean recently published a study, it's actually already been 3 years, where she looked at large commercial insurance databases, and she saw over 200,000 young adults who received a stimulant prescription for attention deficit hyperactivity disorder. And among those patients, those who had an episode of psychosis within 60 days after starting the medication was higher among amphetamine users than among methylphenidate users. The risk was about twice as high if you're taking Adderall compared to if you're taking Ritalin. And of course, Adderall is a stronger stimulant. It's more dopamine releasing in the brain. So what this is probably saying is that people who are at risk for psychosis, if they start to take a strongly dopamine releasing drug, that actually increases the risk of having a psychotic episode. Now, the absolute risk is low. We're talking about 0.1% versus 0.2% of all people. So it's not like everybody who takes these medications is going to have psychosis. But the relative risk is still higher for the medicine that actually has the higher dopamine releasing capacity. So we need to be mindful of stimulants in people who have ADHD, but who may also be at high risk for psychosis. So that's the earliest stages, the at-risk states. Where are we in terms of early psychosis treatment issues in the first episode psychosis clinics, once people have developed psychosis? Well, once again, I'll give you the punchline right off the bat. The standard of care in early psychosis is coordinated specialty care, or CSC. This is not just putting up a shingle and having a doctor or a therapist saying, we'll take care of first episode patients. It's team-based care. So this is actually a program that you set up and train your staff accordingly to provide CSC. It's comprehensive, all aspects of psychosis and mental health. It's intensive, similar to ACT or PACT teams that many of you are probably familiar with. So the idea is that you're providing assertive care to people. It's not just sitting in the clinic and waiting for them to come to you. It's person-centered, focused on engagement, and it's recovery-oriented, prioritizing return to work or school. So these two really are that hopeful message that I was giving at the beginning, that having a psychotic disorder is not a life sentence. It's not, doesn't mean you're destined to never work again and not have any friends, not have any relationships and all the rest. It's actually possible to recover and to have a good life. And treatment should have that as the goal. Of course, we're not going to accomplish that every time, but that should really be the goal. Psychoeducation, including for the family. Phase-specific treatment, here again, the antipsychotic medication example I gave. You want to be mindful of where the patient is and deliver intervention that will benefit that patient. And time limited. Usually CSC programs are for 2 years, at least at the outset. There's some evidence that suggests that extending to 5 years may be useful, but this is a scarce resource. Not every patient who needs CSC is getting CSC. So we want to be able to take care of as many people as possible. And one way to do that is by keeping the treatment time limited so that you can send patients, existing patients, to other programs as appropriate and bring in new patients. The prototypical study in the United States was the RAISE study. RAISE stands for Recovery After an Initial Schizophrenia Episode. It really established that CSC is superior to treatment as usual in a large, multi-center, well-done clinical trial. So we have really strong evidence for this. And at this point, we actually have meta-analytic evidence. So across multiple studies, when you look at early intervention services versus treatment as usual, early intervention is superior for pretty much everything you look at, including treatment discontinuation, hospitalizations, remission and recovery, various kinds of symptom severity, psychiatric hospitalizations, and also global functioning and quality of life. So early intervention is really the name of the game for first episode psychosis service. But of course, it's not the final word. CSC is just something that people designed, taking elements that they thought might be reasonable, but people are starting to think about what comes after CSC. So Macheri Keshavan, who's here in Boston, has been writing along with his colleagues like Emily Klein about RAISE Plus. So there must be other things out there that we can do to further improve outcomes after CSC. A couple of examples. One is cognitive enhancement or cognitive remediation for patients who have cognitive deficits, since that's common in the psychosis population, but it's not always, those patients aren't always getting cognitive remediation. Another one is peer specialists. So we know that peer providers, people with lived experience themselves, who then get some clinical training and then work as clinicians to provide care to others like them who are now getting sick, is actually quite effective, but that's not an automatic part of CSC. So there's interest in incorporating that, and there's others out there like this. There's some other interesting data. I'm just going to give, this is an old paper from the OPUS trial, which took place in Denmark almost 20 years ago now, but they have more modern updated data on real world outcomes. So in this case, Danish researchers took the control arm and the OPUS arm from their original clinical trial from 2005 and compared that with how OPUS clinics are doing today in the real world. They have a network of clinics in Denmark called these OPUS clinics that deliver the same care. And the question was, are the real world outcomes as good as what you see in the randomized controlled trial? And the answer turned out to be even better, which is really remarkable. So in terms of psychiatric hospitalizations since the end or the beginning of treatment, and mortality, percent mortality, people in the real world OPUS clinics actually did even better than what you saw in the randomized controlled trial. So this is a really hopeful message that it's not just research evidence. It's not just doing a clinical trial where you can show that this works. You can actually open those clinics, let the clinicians take care of the patients around the country in a place like Denmark, and of course in the US too, and the outcomes are going to be at least as good and maybe even better. In terms of suicide, the outcome was actually comparable to what you saw in the clinical trial. But this orange curve, the way it actually diverges from the red and the green, is really hopeful message that these clinics in the real world can deliver good outcomes. I already mentioned duration of intervention. This is one of the areas of existing controversy. There is divergent approaches across existing clinics. Some clinics provide longer duration because it might lead to better outcomes, whereas others actually try to provide shorter term because it's a scarce resource and they want to take care of more patients. Some clinics are experimenting with step-down specialty clinics. So if you can provide CSC to everyone, can we do a CSC step-down after 2 years so patients are still getting something better than what they would get in the community? It's specialized, but it's not the same level of intensity as the first 2 years. And then some patients come less frequently on their own because they're more functional and they don't need as much help, whereas others may need frequent ongoing care for relapses and disability. So there's self-stratification. The good outcome patients start to come less, and the poor outcome patients actually need more. So those are the issues that are being debated in how long should this intervention really be. There was actually a Cochrane review a couple of years ago looking at exactly this issue. They saw that there's preliminary evidence of benefit for extending the early intervention, but the quality of evidence was actually quite poor. So it's sort of the jury's out. We can't really say that there's strong evidence that clinics should go to 5 years. Right now, most clinics typically have a 2-year duration, but again, with some clinics that go to 5 years. Another debate is around first episode mania. Of course, many people with first episode mania also have psychotic symptoms, and first episode of people with bipolar disorder tend to have outcomes that are somewhere, on average, somewhere between people with schizophrenia and the rest of the population. So we should be doing something for early intervention with these folks as well. And this article argued that patients should be cared for within a first episode psychosis service when such a service exists. So in other words, if you started a first episode psychosis service and you get a patient with clear mania or mania with psychotic features, these authors would argue that those patients should be taken care of in the same clinics. Just take that patient in your clinic. At McLean, this is exactly what we do. We don't have a diagnostic exclusion when we get people with first episode non-affective psychosis, looking like schizophrenia, or first episode psychosis, first episode affective psychosis, looking maybe like bipolar disorder or maybe schizoaffective disorder. We take them all. And when we do that, our clinic population, first episode clinic population, ends up being roughly half and half. So 50% of them end up having an affective psychosis diagnosis, and the other 50% a non-affective psychosis diagnosis. Another debate is around the role of antipsychotic medications. So this paper created a lot of controversy. Although it's almost 10 years old now, I still like to show it because this is a first episode psychosis paper from Holland, from the Netherlands in Europe, where they stabilized everybody on medication for a year, and they randomized people, half of them to stay on the full dose of medication, and the other half to lower the dose and maybe even come off of the medication altogether if they could. And what they saw was that in the first couple of years in this pinkly shaded region, they saw exactly what you would expect. There was more relapses in people who were actually coming off of the medication. But then if you keep watching them over 5 to 7 years, the two curves actually crossed to indicate that people who are on lower dose of medication or no medication at all were more likely to stay stable and more likely to be functional in terms of their functional status. This is just a single study from the Netherlands. It doesn't prove that, you know, antipsychotic medications are bad for you. There are so many potential explanations in terms of medication side effects that may keep people from going out and getting jobs or you know, going to school, or the self-stigma of having to take medication or being reminded every day that you have a mental illness might play a role. They came up with lots of explanations. It's hard to know exactly what happened here. So we have not gone out to take our patients off of antipsychotic medications, and neither should you. But it's good to be aware that we don't really understand the full long-term impact of antipsychotic medications after a first episode of psychosis. So there really should be more research into this. But of course, many experts have written articles reminding us that randomized controlled trials strongly support the efficacy of antipsychotics for acute treatment of psychosis and for prevention of relapse. Correlational evidence suggests that early intervention and reduced duration of untreated psychosis also improves long-term outcomes. So those bits of information would argue that antipsychotic medications improve outcomes in long-term outcomes in first episode psychosis. So we just need to be mindful of this and look at the literature in the future, because there's a need for more studies along these lines. So those are some of the treatment issues that I consider to be controversial, or where there's active debate and active research. I'm now going to move on to Epineph, which is a national consortium in the United States that hopefully can make a contribution to these. So Epineph stands for Early Psychosis Intervention Network. The goal is to accelerate advances in early psychosis care, recovery outcomes, and scientific discovery through a national early psychosis learning healthcare partnership. The Epineph is funded by the NIMH. There is a website at the bottom right of the slide here that you can visit if you're interested. It includes 8 regional hubs, and each hub has multiple clinics associated with it. So there are 101 early psychosis clinics across 17 states within Epineph. And there's also a national data coordinating center. So the idea is that the NIMH is funding collections or groupings of clinics. For example, we have a network here in Massachusetts with 6 clinics, and it's one hub, and total of 8 hubs around the country, bringing together first episode psychosis clinics. And it's estimated that there are over 250 first episode clinics in the country. So 100 of those are already in the Epineph. And the goal, the vision, is that this will continue to grow, and that we're bringing them together into a single platform where all of these clinics are working together using the same data collection techniques and using the same early intervention philosophy to improve care and outcomes for patients. So this slide is just the geographic distribution of these clinics. And as I mentioned, our LEAP Center at McLean is one of the hubs, but then there's others in New York, there's clinics in Florida, Indiana, Illinois, Minnesota, Texas, Oklahoma. I don't see one in New Mexico, but they do exist in California. But the goal is to expand and grow these networks. So hopefully there will be more in the future. And the vision for Epineph is what's called learning healthcare. So NIMH wanted to start a system of learning healthcare for first episode psychosis. And before I go into what's on the slide, let me just say, the idea behind learning healthcare is that you study what you're doing in clinical care delivery. So as you're taking care of patients, you're also collecting data about that process, about clinical data collection, about clinical care. And then after you've collected your data, you study your data. You look at which kinds of patients do well with which treatments versus those that do poorly with other treatments. Or, are there specific trajectories of outcome that you can learn about from studying these patients over time and so on. And then you change your practice based on what you just learned. So it's really circular, that you're delivering care, collecting data, changing practice, delivering care again, and so on. The concept actually was introduced by the Institute of Medicine about 10 years ago now. They really strongly advocated for digital capture of the care experience, measurement-based care, and then continuous quality improvement. So changing what you're doing, evolving standards of practice, and then feeding that back to the clinics so that there's real-time access to knowledge. And then NIMH is now emulating this within Epineph, really following what the Institute of Medicine has done. And I already mentioned this sort of circular, idea behind the learning healthcare system for early psychosis, that you have your clinical experience, and then you collect data and you change what you did through quality improvement, and then you collect the data and study it, so you actually have more scientific discovery and you go back to the clinical experience and so on. So if you do this, what might you be able to accomplish? For Epineph, this can mean personalized treatment, actually seeing groupings of patients, and some patients respond better to some treatments than others. So it creates this platform where you can study this with literally 100 clinics. The goal is to have over 10,000 patients whose data are being collected for Epineph. And so you can study all of this. You can also kind of deploy randomized quality improvement projects. You can have half the clinics around the country doing one thing, the other half doing another thing. Then you can compare outcomes. You can rapidly pilot or field new approaches. So once you've decided this is really the way it should be, you can use your Epineph network to say, okay, clinics, all of us need to be doing it this way going forward and not that way. And then you can also evaluate rare events with statistical power, things like suicides, completed suicides, or hospitalizations that are more difficult to study in smaller groupings. But if you have 10,000 patients that are followed over several years, and then even more being added every year, you might be able to capture more of those rare events as well. So there's a lot of promise for what Epineph is trying to do and the platform that it's going to generate. The kind of lifeblood of Epineph is the Common Assessment Battery. And again, if you go to the website, you can see the Common Assessment Battery for yourself, or the CAB. It captures many domains, and I'm going to get to that in the next slide. It's being used by all of the Epineph clinics already. So we in Massachusetts have started collecting CAB data on every patient in all of our first episode clinics. And then we're reporting that to headquarters, so to speak, to the National Data Coordinating Center. And that's all becoming concatenated with all of the data from all the other clinics around the country, so that that can all be compared and contrasted and studied in a certain way. So the CAB is already active, and these are the domains within the CAB. You'll see cognition, demographics, diagnosis, discharge planning, DUP, education, employment, family involvement, functioning, general medical health, hospitalizations, legal, medication side effects, medications, recovery status, service use, shared decision-making, stress, trauma, adverse childhood events, substance use, suicidality, and symptoms here being mostly the psychotic symptoms. So the idea was to create a CAB that covers as much of the waterfront as possible, but will still be usable by clinicians and patients. Because, you know, if you ask them to do a 3-hour assessment as part of their routine clinical care, it's just not going to happen. But this CAB can be collected within about 45 minutes, and we're asking people to do this once every 6 months. So that becomes much more manageable for most clinics to be able to collect the CAB data once every 6 months, and then, you know, incorporate that into their workflows. It's still a big ask, and of course it's tough. There is a lot of tensions around it, of, you know, trying to get clinicians and patients to fill out, because there's patient assessment parts and clinician assessment parts, and that's been an uphill climb. But still, it's at least within reach compared to asking people to do, you know, standardized skids or other kinds of interviews that take a lot longer. That's Epineph, and I'll show you a few kind of, you know, real world applications of Epineph within LEAP and Mapnet, which is what we're doing in Massachusetts. So the LEAP Center was launched in May 2019 with that P50 grant. It's the point, the goal was to take advantage of policy changes enhancing early psychosis care financing. This is the SAMHSA block grants that were given to all the states to take care of first episode patients, but also practice changes in the field, methods developed outside of mental health. This is from especially HIV care and cardiac care. There's a lot of cutting edge statistical approaches to complex chronic disorders that we collaborate in collaboration with our colleagues in the School of Public Health here that we want to be implementing. Converting large amounts of data into useful clinical and policy knowledge and support national efforts. So this is the Epineph part, really. Here's the website. If you're interested, you're welcome to visit. We collaborate closely with DMH's Mapnet program. So DMH is the Department of Mental Health in Massachusetts, and the Epineph branch in Massachusetts is Mapnet, and they are collecting the data and implementing all of the Epineph activities. And at the LEAP Center, we work very closely with them to support them in doing this, and then also, you know, starting to do some data analysis. Mapnet was started actually even before our LEAP Center was in 2018. The original PIs were Macheri Keshavan and Emily Klein. Kesh, as we call him affectionately here, Kesh is still involved with this. Mapnet offers technical assistance, trains the first episode clinics and the service providers, organizes learning collaboratives, does consultations for difficult patients, workforce development programs, and so on. So Mapnet, you know, is active in supporting first episode clinics all across Massachusetts. It's worked with 13 clinics within Massachusetts and actually launched 7 of them. So Mapnet literally hired the staff, trained them, got the space and then sort of opened the clinic. So they've become really active in this business of taking care of first episode patients. They created a referral system across all of our clinics. So there's one phone number, one email address. If you are looking for first episode care, you don't have to go anywhere else. You can go through Mapnet and they'll place you in the clinics. They also do fidelity assessments. So they do day-long site visits, including chart reviews, staff interviews, and so on, to make sure that the clinics, as they're going on, are delivering care that has fidelity to the model of CSC. And then, as I said, they're also responsible for data collection and reporting to SAMHSA. They had their own CAB before we got involved, but now we've converted to the Epineph CAB, that National Common Assessment Battery. So, we're collecting the exact same data in Massachusetts as all other clinics in Epineph are doing. We've already started publishing some of the experience related to this. We published a brief paper on lessons learned from a pilot implementation of harmonized data collection. This is the paper where we discussed some of the challenges that I was mentioning about getting clinicians and patients to agree to do the data collection and see that this is in their best interest, because the data that you collect comes back to you as information. And you can see how an individual patient is doing, their trajectory over time. Or you can look at a clinic and quickly see what percentage of patients are smoking cigarettes, or what percentage of patients have no insurance, or anything else that you're interested in that comes out of that assessment battery will be in there. So it's a really an iterative process of trying to collect data, feed it back to the clinics, and then collect more data. The other big thing we did between LEAP and Mapnet is a statewide strategic plan for early psychosis care. So we hosted 2 meetings, annual meetings, whole day, attended by over 100 people. It brought together patients, families, community partners like NAMI and others, frontline clinicians, researchers. We had representation from Massachusetts Medicaid and also commercial insurance, and the state policymakers, the DMH, leaders that actually decide how to spend the dollars. We're all in the same room. Well, unfortunately, it was virtual both times, but we were all together on Zoom, and there was a series of presentations and a really lively discussion that actually led to the drafting of a statewide strategic plan that talks about access for patients who need early psychosis care, that talks about diversity and inclusion of all people in the state who need this kind of help, and also diversity in the ranks of our clinician workforce. It also talks about support for the clinics to avoid burnout, because these are actually, heavy burden clinics. There's a lot of work, and many of our clinicians start to burn out after a short period of time. So the strategic plan looked at all of these issues and how to support everybody. And it's actually on the website. So if you go to our website, you'll see it. This was the second one that happened last November. And now the statewide strategic plan is also on our website. So some of the things I already mentioned: access to care, which really boils down to expanding capacity. I don't have a slide of this. We recently did a paper, again, with our epidemiology colleagues, where looking at the statewide database, we estimate that there's about 1,100 young people a year that are developing a first episode of psychosis within Massachusetts. And that's roughly within the range of what you would expect from overall national numbers. So 1,100 people a year. If you look at what is our capacity in the clinics, our 13 first episode clinics all around Massachusetts, we do about 100 new intakes a year. So less than 10% of all the needy patients are getting this kind of help, this specialized help. The remaining 1,000 people, they're in emergency rooms, they're in inpatient units, they're in psychiatrist offices, they're in community mental health centers. Some are in pediatrician and primary care clinics, just bouncing all around. There is no system of care for them. And this really tells you, and this is Massachusetts, which is a relatively well-funded, well-organized state system. If you go to other states, I would wager that things are going to be the same or worse. So we really need to expand capacity and serve the people who need the help. Think of Denmark. Think of those orange curves, that if you actually open clinics around the country and you deliver this kind of care, the real life outcomes can be, lower mortality and fewer hospitalizations and a variety of other better things. serving underserved communities and diversity in clinical teams, I mentioned. Staff burnout and turnover, I mentioned. The other interesting idea that came out of our meetings, which hasn't yet been implemented, but we're looking into this, is a residential or inpatient service dedicated to first episode patients. Because patients and families, they were so clear, and the message came through loudly, that when you take a 19-year-old who's just getting sick, throw them in the ED. I mean, of course, we don't throw them there, but they end up in the ED, and then they come to a routine, inpatient unit with a bunch of other people who are in their 40s and 50s and who've been sick for 20 years. That is so jarring and destabilizing that it actually becomes counterproductive. People get afraid of care and they don't want care anymore. And that's the exact opposite of what we're trying to accomplish. So people were very clear that if there was a service that took care of first episode patients, that might really change long-term trajectories for some of our patients, because it would change how they see psychiatry and how they see mental health care. We also wrote up a paper about the strategic roadmap for Massachusetts that just appeared at the end of last year. And now we're starting to analyze the data. So this is the first paper that came out of the Massachusetts data set. We looked at COVID impacts. And here I'm showing you employment and education. And the stay-at-home orders, the public, state-ordered closures of schools and work was these vertical gray bars. And I'm showing you 2019 when there was no epidemic, and 2020 with the stippled line when there was an epidemic. And this is among 128 patients with first episode psychosis in Massachusetts. And you see that for both employment and education, of course, there was basically a very significant reduction in the proportion of people who could work or go to school because it was the early stages of the pandemic. But then as the year of 2020 wore on, there was actually a recovery in education in the fall semester. As the kids went back to school, there was a decent number of them that actually started to go back. And that started to reach the levels of the previous year. So there was a recovery in education, but there was no recovery in employment. Our first episode patients took a hit to their employment abilities, and they did not recover from it. So this is Massachusetts data, but it's very interesting early observation. We are now looking at the 2021 data, and the scarring in employment seems to be there still, but although not as bad. So this is an observation that we collect from the Epineph effort, because we're collecting this data regularly so we can see what's going on with our patients, and then we can follow them along and draw this kind of conclusion that we need to focus on employment, because our patients did not recover their employment rates after the pandemic. So some of the data analyses we're doing is the COVID-19 impacts. One interesting thing here that's happened is about telehealth and virtual care. Of course, we're on Zoom right now, and so many of our patients are receiving care on Zoom. And that works okay for some people, but not for everyone. And that might generate disparities, so we have to be mindful about that. And I already talked about the tensions around the data collection. It takes time commitment from clinicians and patients. And then reporting of CAB data back to clinicians is a big priority for us. Some of the other things we're looking at, treatment duration. How long do people stay in our clinics, and should we offer them something longer? Outcomes in individuals who were referred to CSC but didn't make it in the door for a variety of reasons. They weren't eligible, or the clinic was full, and so on. But these are people who were referred, so we know somebody thought that they should be in a CSC clinic. And we think that the outcomes here are poorer, and that demonstrates the value of that real-life CSC intervention. We already talked about cannabis. We're interested in the impact of cannabis on first episode trajectories. And then first episode affective psychosis we also talked about. Okay, I'll leave you with a couple of conclusions here. Hopefully you can see what a lively field this has become, and some of the debates that are taking place. So transition is underway from research to implementation of evidence-based early psychosis care. This is really an international issue, with a lot of leaders in Australia, in the UK, in Europe, and elsewhere, but also in the US now it's starting to happen. There is more availability of resources to provide early psychosis care, and that has made a meaningful impact, although we need more. There is also, through Epineph, a national opportunity for creating a learning healthcare system around early psychosis. But local and national collaboration will be essential to make ongoing sustained progress. And there's much to learn. Details of intervention, duration, what population, those are all questions that are still being debated about what is the best early psychosis intervention. And then, of course, the big $64,000 question is, can we bend the curve in the real world? Because if we really could, if early intervention changes outcomes the way it did in cancer, we might be able to change the face of psychosis and psychotic disorders in human societies in the coming period, and that would be very exciting. I'll leave you with an aerial view of McLean Hospital. I'm not going to pretend that it looks like this year round. You know, we had snow on the ground until last week, so it's sometimes different. But you know, it's a great institution, and I'm really happy to be doing this work here at McLean. So thank you for your attention and your interest.
Thank you, Dr. Öngür, for an inspiring talk. As you're aware, we do have our CSC clinic here that has a very distinguished group of individuals who you know, Juan Bustillo, Don Hoffman, Bess Friedman, Rochelle and Ruth. And some of the things that you talked about is something that we want to start here in New Mexico. You did show the map where it didn't show that New Mexico had a net, and that is certainly one of the goals. We also have a clinical high-risk clinic led by Dr. Root. So this has been a very important work for us that we want to continue. As you pointed out, Massachusetts is among the 3 wealthiest states in the country. That's great. New Mexico is among the 3 poorest, which is not good at all. It's terrible. On the other hand, it gives us opportunity. It gives us a great opportunity to make change. So I'm sure the members of our team want to share their thoughts, and I can see Dr. Bustillo and Bez raising their hand. So thank you again, Dost. This has been truly inspiring. Dr. Bustillo.
Thank you, Dost. That was a wonderful presentation. I mean, you really went through a lot of critical issues that are relevant for us clinicians. I want to go back to something you mentioned at the beginning of your talk, and it's really not the main focus of the talk, but it refers to the Crippleinian dichotomy and the usefulness of the Crippleinian dichotomy. That, you know, I'm sure this is cyclical. I mean, it's been around for so long, and it's happened maybe I bet more than once, but certainly the last decade, there's been a big push to question the fundamental concept that prognosis of schizophrenia is worse than the prognosis of bipolar disorder. And this is a fundamental truth that is important. And we just need to find what underlies this. So my question is, you know, do you think, what's the place of that Crippleinian dichotomy now for you after working for so long in first episode clinics and doing research? I mean, is it done for? Is it still useful? Is there an alternative? And also, is it useful not just for researchers but for clinicians? So I'd like you to expand on that.
Yeah. It's a great question, Ron. So I think that, you know, it wasn't a total misunderstanding and we should just completely scrap it. I think there's some features that really ring true. I mean, when I think about long-term outcomes, for example, in our clinic, we have a physician, a social worker, school teachers, PhDs who've received care in our clinic. But every one of those people that I just mentioned has a bipolar disorder diagnosis. They don't have a schizophrenia diagnosis. So on average, there's no doubt that that diagnosis tracks something meaningful. We also have people with schizophrenia diagnosis that are doing great. So it's not like schizophrenia diagnosis is destiny that you're not going to function. But, you know, on average, you just see that distinction play itself out. So I think it's really good to be mindful of that. There was some reality to it. The problem is that, you know, those classic cases are not very common. They're a minority, you know, where you see a classic bipolar case or a classic schizophrenia case. And then the majority of patients have something that's you know, has features of all, and then they change. So one thing, you know, that I've really learned so I don't do frontline clinical work in our first episode clinic, but I do consultations and I join staff meetings. So I hear a lot of the patient stories and I see some of the patients. And I have had egg on my face more than once, you know, saying, this is what's going on. And then 6 months later, they stop me in the hallway and they go, my staff, remember that patient you said this is, and it's totally different now. We had one memorable patient who I thought had, positive symptoms and negative symptoms and classic, nuance at schizophrenia, and turned out to be in a deep psychotic depression, and came out of that and then became manic. And, and then he ended up with a bipolar disorder diagnosis. And was it that, I wasn't smart enough to see that? Maybe, but I also think that people genuinely evolve. So we need to be humble about diagnosing people early and using that to predict outcomes. You can do that as time goes on and you feel like you've really seen, at least a year, probably more, of a patient's evolution, and then you start to get a better sense. But so that dichotomy is both useful and misleading at the same time. That's my answer, I would say.
Great, thanks.
Yeah.
We'll move to Bez, but let me make a comment here. I would almost say that instability of diagnosis is ubiquitous in psychosis, as the data from McLean has shown. Bess, you're next.
Hi, and hi, Dr. Öngür. I actually have more programmatic type questions for you. So one question I have is whether you know if Epineph provides any funds that can be used as an incentive for clients at CSC programs that are going to contribute to WebCab. So for example, we would like to participate, but getting clients to agree to do this survey and to et cetera, is that something that Epineph has thought about? And do you know anything about that? Should I get in touch with Dr. Heinsohn?
Yeah, I don't know the answer to that. I'm guessing that there isn't any, earmarked funds for that. But if you approach them with that question, they might be interested in working something out because they're very motivated to expand the clinic, to expand the network rather. And then in the funded Epineph grants, it was possible to put some funding, to enhance data collection in these various ways. So I know that it's already being done for some of the Epineph sites. So I think they might be interested. It's Bob Heinsohn, but Susan Azarin is, I think, the direct scientific contact for this. So
okay,
you could ask her.
Great. Thank you.
And I don't know if people heard, but Bob Heinsohn is actually stepping down from his role. He's going to sort of, phase out from the active full-time work, and he's going to become a senior advisor to the NIMH director. So that's July 1. It's such a big change for the field. He's been so important for so long.
Thank you, Bess, for that question.
I have a quick follow-up question.
Please.
Mapnet uses the fidelity scale that I designed for Pennsylvania. And I'm wondering who I'd get in touch with about that for collaboration around a paper.
Oh, sure. So yeah, so there's a couple of things. There's a Don Addington scale that is that the one you're referring to? The FEPS? No,
the scale that Mapnet uses for fidelity just within the state.
I see. Well, they're transitioning now to FEPS actually, so that's one thing. But still, I can put you in touch with it's Kelsey Johnson, who's the Mapnet administrator now. If you can write me an email, let me just put my email in the chat here. And for anybody, really feel free to reach out about anything we talked about, and then I can put you in touch with them, right? Because they are transitioning, but there's still a lot that has happened with that. So yeah, it'd be and it's through Monica Calkins that I think that relationship was formed initially. That's right.
Yep. Thanks.
Great.
Dr. Waldorf.
Yes, thank you. Just one quick question. I work with transitional age youth who have substance use disorders, and certainly we see exactly what you're talking about with regard to amphetamines and cannabis with early onset psychosis. I'm just wondering what the most current data is with regard to any specific drug classes related to first episode mania.
That's a good question. Dr. Tohen might have something to say about that. I would guess steroids, but I don't know that there's good sort of systematic data on that.
Okay.
Marcio, do you know?
Yeah, it's actually question that has been raised for a number of years. And at some point, people thought it would be diagnostic. If the first episode of mania was triggered by the use of a stimulant, that actually was a predictor of that instability of diagnosis would stay for longer. But it is of course very important. Actually, in a few weeks, cannabis is going to be available for recreational use here in New Mexico, so that we should take advantage of, should we say, this naturalistic opportunity. Yeah. And Dr. Waldorf, that would be a good question to study. It is top of the hour. Can you take one or two more questions, Dr. Öngür?
Yeah, I can stay. I have a 4 o'clock, but I can stay a couple of more minutes. Yeah.
I can see that Dawn is ready to ask a question. She's the leader of our clinic.
Actually, no, I actually have to duck out because I have another meeting. But thank you so much, Dr. Öngür. This was wonderful.
You're welcome.
I'll probably
Thanks.
email you.
Great.
Thank you so much, Dost. It really was quite inspiring. It brought me a lot of memories.
Yeah.
So this is wonderful. Thank you for
Thanks very much. Thanks for the invitation.
And thanks for also for that, Maria Yellow Horse Braveheart. So I put a comment about cultural engagement.
Yeah. Yeah, I saw that.
The ceremonies do work because people really believe in that. And so I think having that holistic approach is really important.
Maria is the national leader in historical trauma, Dost.
Absolutely. No, I think, I mean, you know, we see that here too. In variety of cultural backgrounds, things play out very differently depending on, you know, how the intervention actually is framed. So I agree.
Thank you.
All right. Bye-bye.